Good afternoon. Thanks for joining Family Caregiver Alliance for Discharge Planning is a Family Affair. I'm Calvin Hu, Education Coordinator at FCA and your host. For 4 decades, FCA has been working across the Bay Area and the nation to improve the well-being of family caregivers. We offer support through consultations, classes, workshops, publications, retreats, research, and advocacy. If you'd like to learn more about us or access our online resource center, FCA Care Journey, please visit caregiver.org. So I'd like to welcome today's guests, Carol Levine and Christina Ramos-Callan. Carol directs the Families and Healthcare Project at United Hospital Fund in New York City, where she led the development of Next Step in Care, which is a suite of educational materials for family caregivers and healthcare providers to help them work together during care transitions. Carol is a former caregiver for her late husband and is also a researcher, writer, and advocate for family caregivers. Her latest books are Navigating Your Later Years for Dummies and Living in the Land of Limbo, fiction and poetry about family caregiving. She holds an MA from Columbia University in Public Law and Government. Our second guest for today is Christina Ramos-Callan. She is a program manager at United Hospital Fund, where she works to promote improvements in the healthcare delivery system, kind of centered around patient and family experience. And she also fosters the kind of clinical community partnerships needed to address the social determinants of health. Christina is also a lifelong family caregiver, and she holds an MA in Urban Studies, Healthcare Administration from the Murphy Institute of the City University of New York. So now that you know a little bit more about our two guests, I'd like to turn things over to Carol and Christina.
Thank you, Calvin, and thank you to Family Caregiver Alliance for inviting us to do this webinar today. We've worked very closely with Kathy Kelly and her team over the years, and it's a pleasure to do this today. Christina and I are going to take turns on the webinar so that we can share our different experiences. And we want to show you a few words about the United Hospital Fund, which is a New York City-based organization. They're independent, nonprofit organization. We analyze public policy around healthcare. We convene stakeholders. We don't provide direct services in the way the Family Caregiver Alliance does, but we do work very closely with patients and caregivers. And Next Step in Care, as Kelvin said, is a suite of probably now about 40 different family caregiver guides and special guides for healthcare providers around different aspects of transitions. And we're going to refer to some of those during our presentation. Our learning objectives today are first to describe to you some of the regulatory issues that may affect the hospital stay and the hospital discharge. We're starting at the hospital stay itself because what you learn in the duration of the stay will really help you prepare for the discharge. It shouldn't come as a big surprise, which unfortunately it often does. Why discharge planning is really important and how family caregivers should be involved in all the major decisions. Christina is going to talk about some of the features of good discharge planning. We're going to show a little video which shows the opposite side. And then we're going to talk about post-acute care. That's a term that I recently learned. I hadn't heard it before. It means only where you go after you leave the hospital, and there are different possibilities. And then we're going to talk about who can help you when problems arise. Okay, I'm going to talk about the regulations that might influence your hospital stay. Some of them will definitely be appropriate for everyone. Some are specific. Next slide, please. The first one is something called observation status, and that is basically a billing procedure. What happens is, you may have had this experience, something happens, a fall, you go to the hospital with your family member, and the hospital, the physician or the care manager there says, well, I think we should keep you here for a few days or overnight for observation. Meanwhile, you get taken to a real room, you get real food or whatever the food is that they're giving that day. You get all the x-rays and so forth. But the important thing to know is if you're in observation, you are not formally admitted as a hospital patient. So for billing purposes, you are being treated as an outpatient, which means that using Medicare as an example, if you're inpatient, it comes under Medicare Part A, there's a deductible, but then everything is covered. In observation status, everything is like you were being treated in a doctor's office. So it's itemized, and what happens is, the end result is the patient or the family has a bill at the end. So you really need to know whether you've been admitted, or the person has been admitted or not. Next slide. The only ways you cannot appeal a decision of being on observation status. You can ask, has my family member been officially admitted, or is she or he under observation status? And probably the best person to ask is someone in the admitting office, because the staff nurse or the doctor, even doctor, may not know. So you should keep a note of who is telling you what. And you're supposed to get, for federal rules, a notice if you're in observation status, but that doesn't always happen. So it's really probably up to the family caregiver to keep track of that. And if the person is in observation, try to find out if it can be changed to admitted, or if they're going to go home right away, then probably there's not such a big issue. The other point at which this becomes important is that when the person who is, say you've been under observation for 3 or 4 days, and then they say, well, you really can't go home. We think you should probably go to a skilled nursing facility. If you have not been admitted formally admitted to a hospital as a patient, as an inpatient for 3 days, Medicare will not cover the SNF stay. So that's when the big money starts to turn up. So it's really important. If somebody says you're on observation, then you have to start checking in about it. Okay, let's go to the next slide. Not everybody will have the observation status, but in nearly 40 or more states now, including California, including New York, where we are, and probably most of the states where the other audience members are living, there is a new state law called the CARE Act. And it's caregiver, advise, record, and enable. It's really intended to ensure that the family caregivers are identified in hospitals and trained to provide post-discharge care, that post-acute care that I mentioned. It only applies to hospitals, although there's talk of applying it to other facilities. The law in each state is slightly different. So if you're in California, you should know the California rules. We know the New York rules. They're basically, though, 4 different elements. The patient is offered an opportunity on admission to identify a family caregiver and document. If the person says, yes, that's my wife, that's my daughter, you document that person's contact information. The patient then is asked if he or she is willing to share medical information with the caregiver. Some states, including New York, require written consent, but that's not true everywhere. And the caregiver is supposed to be informed about the expected discharge date. And one of the questions that we received was about, well, what is the expected discharge date? Well, it depends on the hospital, depends on this person's condition. The CARE Act doesn't set any standard. I would say that practice now is showing that you really need, the day of discharge is not a good idea. The day before, a little bit better, but probably 2 days before would be the best that you could get. You may not always get that, but the caregiver has to keep asking, well, Dad's doing better. When do you think he can go home? And that way you get a sense of what the staff is thinking about. And finally, the hospital staff is required to provide instruction about care at home. It can be done in any number of ways. Usually it's something written. It could be a demonstration by a nurse. It could be a video. But it should be something that will at least get you home safely so you know what you're doing. If there's home health care coming, a visiting nurse, then the instruction should continue, but it's a start in the hospitals.
Next slide, please.
Hospitals, apart from the CARE Act, from the federal regulations, they're required to establish a safe and viable discharge plan, even if the caregiver, if the patient says, I don't need a caregiver, I can take care of myself. Hospitals are not required to delay a discharge because the patient has not named a caregiver. So hospitals are protected in the CARE Act this way. And so as a family caregiver, if you feel that your parent, for example, may not want to name you or name someone else as a caregiver, you really need to talk to them ahead of time if you can and say, you know, this is just temporary. This is just so you can get home. The caregivers have to be willing to do this. This is not a forced role. You may be pressured in a number of ways. You may feel the pressure yourself from your own background that this is something you should be doing. But if there are reasons that you can't do it, health or other family responsibilities or job, or simply it's too much, you need to say that. One thing that's important to recognize is that even if you're named a caregiver and agree to be the caregiver, it does not create any new financial obligations to you, and that's important. If you already have those obligations, they will continue, but otherwise there aren't new ones.
Next slide.
And this is my favorite because it's the one I least understand. It's a bundled payment, and this again has to do with money. A lot of things have to do with money in healthcare. And the way this may show up is that the nurse may say to your parent or your husband or spouse, "Are you in a bundle?" Well, what that means is, does your healthcare plan have they created a set of services, an expected length of stay, expected discharge to a certain facility or not, that will allow them to kind of plan the financial aspect of it. And it does provide a level of efficiency and some kinds of assuring that all of the elements of the plan of care are included. It can also be, it has been criticized for not being flexible enough to allow for the different changes in a patient's condition. Right now, the most common areas where there are bundles are joint replacement, renal failure, or a cardiac implant, some kind of cardiac abilities or disabilities. So right now we don't know a lot about how this is affecting patients. So it's something that you will need to sort through with the health plan and to make the case, if you need to, that the bundle needs to be adjusted to suit your family member's care. This does apply to everyone. HIPAA. This turns up in a way you as a family caregiver, you see the doctor coming down the hall and you say, "Oh, you know, what was the result of that test that she sent my dad to?" The doctor says, "Oh, I can't tell you because of HIPAA." Well, that's just wrong. The HIPAA is intended, it's a federal law, it's intended to protect the privacy of a patient's medical information from people who would use that information for their own needs, financial or otherwise. HIPAA allows hospital staff, healthcare providers to talk to family caregivers as long as the patient does not object And as long as the caregiver, the person is involved in the care or paying for the care, was never intended to be a kind of barrier to communication. Unfortunately, the way it was introduced, it had a lot of scary elements, and then people were afraid to talk to family caregivers. But you, as a family caregiver, are entitled to know what's going on, because especially when you go home, you're expected to take on over this care. So you need to do it. So when somebody says, I can't tell you because of HIPAA, just say they're wrong and go to the hospital privacy officer and get it straightened out. Okay.
So now that Carol's run through the regulatory issues that may affect hospital stays and discharge plans themselves, next slide, please. We wanted to share with you a little bit more about what we're going to call a not uncommon vignette, a vignette of a not uncommon or typical discharge experience from the caregiver and patient's perspective. Next slide and video.
My patient is a 78-year-old female with a history of heart disease. She is in the hospital because she fell at home during a dizzy spell and broke her hip. The patient's surgery went well, but she has not responded as well to the rehabilitation process. The physical therapist's report indicates that the patient has been willing to do exercises, but has not shown significant gait stability. Although there was no documented note indicating the need for further inpatient treatment, the physical therapist told the discharge planner and me that the patient would benefit from a few more inpatient days. The cardiologist has seen the patient and recommended increasing the dose of her antiarrhythmic medication and sees no reason why she cannot be followed as an outpatient to assess her response. He has no opposition to discharge today, especially after I told him that the daughter is very involved and can monitor her symptoms. I asked a pulmonologist to stop by and evaluate her because the physical therapist says she gets short of breath easily. She ordered pulmonary function tests and a chest x-ray, but I doubt that there's anything going on. The chest x-ray is clear, but the other test results won't be available until tomorrow. The social worker would like more time to plan for home visitation services, but the discharge planner notes that the patient belongs to a Medicare HMO, and it feels that the patient is stable and can be discharged. Besides, the daughter can hold the fort until the patient is seen in 1 week. Let's push for discharge today.
The patient is my mother. She has been living alone since my father died 4 years ago. I was worried that something like this would happen because I don't think she takes her heart medication all the time. She wants to be independent, but she really can't manage by herself anymore. I really can't afford to help her much financially, but she won't even accept the little I can offer. At least she'll be here in the hospital for a few more days until she's stronger and can walk. I got here early this morning to talk to the doctor. He's never here when I am. I hope he comes soon because I have to get to work. I've missed 3 days already this week, and I can't come right after work because I have a conference with Thomas' teacher, and I haven't had time to take care of anything at home.
Good morning, Mrs. A. I have good news for you. Your blood pressure is stable and your hip is healing very nicely. You can definitely go home today.
Oh, doctor, thank you. I can't wait to meet my own bed and eat what I like. This hospital food is terrible.
Well, you're going to have to stay on your special diet, no salt, low fat. I'm sure your daughter here will prepare your meals so that they follow the diet and taste good. And I'm going to increase the dose of your heart medicine. I don't want you to fall again. Someone will be by a little later with the paperwork, and then you're out of here.
My mother hasn't even been able to walk alone. Is it safe for her to go home?
She'll do fine. You can help her get to the bathroom, and make sure she doesn't stay in bed all day. She should be walking as much as possible.
But my mother lives alone. Won't she need help?
Doesn't she live with you? Well, can she stay with you for a few weeks? If you don't want to do it, speak to the social worker on the floor. She'll find out if your mother is eligible for any home care. I'm sure we can work something out.
I can manage on my own. I don't want any strangers in my house.
We'll talk about that later. And why are you increasing the dose of her heart medication? Are there any side effects?
She's been on this medication before. There's really nothing to worry about. Of course, if something seems wrong to you, call me right away.
What a nice man. So happy I'm going home.
Yes, Mom. I'm glad you're going home too.
So that was a lot of information packed into a pretty short video, but I want to go over a few things. So we saw that there was conflict between the caregiver and her mother over the plan of care and who was going to be able to provide what kinds of care at home, as well as the reasons behind why the patient was going home, why she was hospitalized in the first place, what the prognosis was, why the medications were being changed. There was misunderstanding between the hospital staff around what the care needs were. The physical therapist thought that the patient needed more time in the hospital and wasn't ready to go home on her own. The HMO was suggesting that the patient was stable enough to leave the hospital. The cardiologist had given the okay, but none of the aftercare, none of the PT that was happening outside of the hospital had been ordered yet, and there were labs still pending. So there was a lot going on all at once right before the doctor says, you can go home and I'm sure you can take care of your mom. So we want to talk to you a little bit more about why good discharge planning is important, specifically because, the fact is it is important, and that was a great example of poor discharge planning. Good discharge planning helps you reduce risk for poor outcomes, which include things like readmission, medication errors, gaps in care, or other accidents and adverse medical events like falls. Safe and adequate discharge plans are patient-specific. They consider the patient's needs as well as the family caregiver's needs. So the availability and willingness that with the patient and caregiver that you just saw addressed, the need for training around why is my mom taking this new medication? Do I have to do anything special to give it to her? What is this special diet that needs to be prepared? And do I have everything I need to prepare it? As well as worries around things like, what if I give medication the wrong way? Or what if I'm not there to supervise? And what if the patient falls down or stays in bed too long and doesn't get enough exercise? These are all really serious considerations for post-acute care, whether in the home or in some other facility setting. Next slide. So what is discharge planning in the first place? Well, at the very least, according to CMS, it's the process used to decide what a patient needs for a smooth move from one level of care to the other. It's not just planning for the physical change in the care setting, but for the entire recovery period, which may last a while. It's done by typically a social worker or a nurse or a care manager, someone else on the care team after discharge has been ordered by a physician. As Carol said before, when does discharge planning happen? Well, it depends. If it's a planned admission, some discharge planning will take place ahead of the hospital stay entirely, such as a planned joint replacement or some other planned procedure. But when it's unplanned, there's an ongoing discussion around patient diagnosis and prognosis, as well as the safety of the discharge, depending on what's going on with the patient. And all of that should happen at least a couple of days before the anticipated end of stay. But as many of us have experienced, sometimes the notice about discharge just comes an hour before. Sometimes the notice of discharge comes when you walk into the hospital in order to visit the person that you're taking care of. Next slide, please. In Next Step in Care, we like to consider everything that we can do in order to prevent a crisis. So a lot of the best caregiving advice we can give is to think through what your caregiving responsibilities and roles may be before you need to use them. So we always recommend that people organize things like personal health records, care planners, medication lists, any medical records or access to medical records you might need, as well as insurance information, the contact information for your doctors, pharmacists, medical suppliers, as well as copies of any advance directives. All of this is done in preparation for a hospital stay or a hospital discharge, but more generally, it's done so that you have all of this information handy for whenever the need may arise. before I move on to the things that we want to make sure providers know, I want to make a couple of points. There was a question in the lead up to this webinar from some of the audience members about advanced directives, durable power of attorney, and healthcare proxy. Durable power of attorney for medical care and healthcare proxy are typically considered the same thing. They're very specific rules around making someone an agent who can make medical care decisions on behalf of someone else. The rules are different from state to state, but for ease of use, a healthcare proxy or a durable or a medical power of attorney from one state is typically applicable in another state. If you're in a situation where you spend a considerable amount of time in a place that is not your home state, you should look into the rules around power of attorney or durable power of attorney or power of attorney for medical care or healthcare proxy specific to the places where you spend most of your time. I also want to specify that power of attorney and power of attorney for medical care are two different things. One is specific to the medical care, and that's what we refer to in many places as the healthcare proxy or the healthcare agent. The other is typically for finances, real estate transactions, and business arrangements. With all of that said, in addition to having all of this information organized, we also want to make sure before a hospital discharge that the provider knows, again, who the family caregiver is and who the primary family caregiver is. So many of us have more than one person involved in the day-to-day care, and we want to make sure that if there's one person who's making decisions or if there's one person who's providing the majority of the care at home, that that's done and that's documented well ahead of time. We also want to make sure that there's caregiver availability and capability to help the patient document it, as well as making sure the provider knows about any professional healthcare services that are already engaged. So if there's a home care agency that you already use or a personal care attendant that's already involved, we want to make sure that the provider knows who those individuals are. Next slide, please. So again, making sure that we can document our availability, our training needs, and our worries are critical for making sure that we can do the best job we can as caregivers. And caregivers can self-assess any of these issues for themselves. On your screen, you'll see a document called About Helping Your Family Caregiver. And that's something that Next Step in Care has created to go through all of the different kinds of worries and around skills training, specific medical tasks, as well as general worries about relationships, team building within families, and the care that's provided at home. Next slide. We divide these worries and training needs into training needs, and availability into these buckets because we want to make it easy for you to think through things like practical things about the time available, whether you're working or raising young children, or if there's any other person that you're caregiving for that's going to hinder your ability to care for this particular person in this discharge plan, whether there are training needs around care coordination or medication or equipment, or simple things like figuring out how to order transportation that need to be sorted out before the discharge happens, as well as the more general things like being able to have work-life balance, understanding what the impact will be on your relationship and how that might change because of your caregiving situation, or just figuring out safety and supervision for things like falls or wandering. Next slide. Carol's going to now talk to you a little bit more about some of the post-acute care concerns that may come up when dealing with a discharge.
Right. One of the questions that we received was about how do staff members in a hospital decide where the patient is going to go? And I think the phrasing the question, we wanted to clarify that the staff don't decide. That's the decision is the patients and the families. But the staff certainly puts together all the information they have about the person's medical history, their clinical condition, likely prognosis, what kinds of needs they're going to have after their discharge to make a recommendation. And the types of post-acute care could be at home, going from the hospital to home, with nursing services or other services, or without them, going to a skilled nursing facility with that's for a short-term rehab stay, not a long stay residential stay, although a short-term stay can turn into a longer-term stay. And those are the two most common discharge plans. There are also possibilities of going to an inpatient rehabilitation facility for a more extended course of rehab, and that's generally for people who've had things like spinal cord injury or traumatic brain injury, where there is a need for specific expertise in rehab, or a long-term care hospital, which is largely for patients who have very complicated medical needs, such as being on a mechanical ventilator. But generally speaking, the two, going home or going to a skilled nursing facility, a SNF for rehab, are the two most common.
Next slide, please.
Caregivers are often, family members and patients too, often very concerned about what is this transition? I just thought I was just going to go home. What are all these choices I'm going to have? Well, the timing is one absolutely critical area. And as we've said, you don't get a lot of time to think about this. And this kind of decision comes often as a bit of a surprise. And often it's not saying, what people interpret it as saying the hospital sent my mother to a nursing home, which really is the hospital recommended that I look at a list of nursing homes and picked one, and there was a bed available at this one, so that's where my mother went. It's not a very deliberative, thoughtful process. It's really what's right then and what's the easiest way to do this. So caregivers need time to consider the option, but time is the least available thing. The information available about a choice is very limited. Sometimes it's due to the hospital's understanding of federal regulations that are designed to prevent steering, which means steering a patient or family to a specific post-acute care facility where they might have a financial interest. And that has created a kind of barrier to giving really good quality information on the part of staff. There's also disagreements about, the patient says, I can go home, I can take care of myself, as the woman in the video, and that it's not really possible. And also even some very good SNFs are not able to provide the kind of specific care that is required. Christina and I recently did, which she'll tell you about, a series of interviews with family caregivers and patients about how they made their decisions. And things came up, and I wanted to, it was important for me to have the facility have on-site dialysis for my husband, so that I didn't have to worry about 3 times a week getting him to another facility. Well, that's not going to be available at all facilities. So there's things like that do come up. And then there's just the general, people don't want to go out. They want to go home. And that's obviously the best place to want to be, but it's also not always the best choice. So there are a lot of interpersonal issues that have to be resolved, especially when families may have different ideas about what should be done. So Christina's going to go into going home, which is the most common.
So typically, if you're going home, you can go hospital to home without home care or hospital to home with home care. Hospital to home without home care is a little less complicated than home with home care, but not by much. Next slide. So we want to talk a little bit about the specific role of the caregiver in the discharge plan. And one of the tools that we like to use for doing this is a checklist, what we call Going Home, What You Need to Know. And all of these checklists are available on Next Step in Care, which you can get to by going to nextstepInCare.org, or you can access a lot of this information through the through FCA's website, where they cross-post a lot of our guides and material. So there are a few buckets of information that are really critical at this point in figuring out the caregiver role. Now that, let's say you've done your assessment, you've thought through what it is that you need to know about your availability, your worries, and any training you might need. The next things you need to consider are the actual physical act of getting home. So that means that you have to know when the discharge is going to take place. You have to make sure that the home is prepared. So if someone's coming home with a mobility device, are there paths that are wide enough? Is there a ramp? Are there any throw rugs or loose materials on the floor that need to be gotten out of the way? And providing or arranging for transportation. Typically, the hospital can give you some assistance with understanding what the transportation needs may be, but for example, if someone is, if you don't have a car and there's some kind of mobility issue, then the patient may need to leave the hospital in an ambulette or some other kind of transport. So all of that will need to be arranged. There are often medical nursing tasks that have to be coordinated, and that may include the coordination of home-based services like visiting nurse, which means that a caregiver will have to be present for the initial visit, not only to just make sure that someone opens the door for the home care service, but also to go through the intake meeting and to sign off on any family agreement documents that may be presented at that encounter. You'll have to have someone available to receive and set up any medical equipment and learn how it works. So things like oxygen tanks, or if a commode needs to be delivered, all of that has to get set up, as well as managing medications, preparing special diets like we talked about before, and assisting with mobility and other daily activities. Doing laundry, preparing lunch, all of those little things that you don't necessarily think about in your day-to-day, but you have to think about really specifically when providing care for someone else. Beyond that, there's the ongoing care coordination of all of the follow-up. So it's, again, being present for the home-based service intake or initial visit, knowing who to call beyond the doctor if there's a problem with the care plan, scheduling post-acute services like visiting nurses or rehab therapists coming to the home, and providing a companionship or any additional supervision that may be required for the person that you're caring for. On the next slide, you'll see a copy of Medicare's Your Discharge Planning Checklist. Similar to the checklist that we just shared with you from Next Step in Care, it's recommendations from Medicare specifically around just making sure that you're asking questions, using something formal to help track all of the tasks, appointments, and new services that you may need to provide, getting ready for any new needs, getting the home ready. And this guide is available on Medicare.gov and goes through many different aspects of preparation, including expenses, key contacts, and thinking about ways to get additional help. Next slide. So both of those discharge checklists that we've presented now have a very specific goal of knowing who you can call about the discharge plan beyond the physician. So don't just call the doctor, but know who can do what specific things to help with discharge planning. So typically social workers will be discharge planners in the hospital setting, and they can also refer to social services out in the community. Patient advocates and patient navigators can help liaise between patients and their healthcare providers on patients' rights, complaints, and grievances, or conflict resolution. So if there's an immediate concern in the hospital during the discharge planning process that you're not getting resolved when you're talking with the discharge planner, you can ask to speak to the hospital patient advocate or the patient navigator, and they can help you. In addition, there's the long-term care ombudsman. So for people who are in long-term care facilities or for people who are being transferred to some kind of long-term care facility. Typically, this is for older adults and persons with disabilities who are eligible for Medicare. You can reach out to that office in order to find out what advocacy services they can help provide for you. The Beneficiary and Family-Centered Care Quality Improvement Office, I know that's a mouthful, I'm going to call it the BFCCQIO, is the regional office that handles Medicare appeals and grievances. So again, if you're Medicare eligible and you have a problem with your discharge plan or your hospital stay and you want to appeal a decision about hospital discharge, then you can reach out to the BFCCQIO while you are still in the hospital, and typically you'd be assigned to a team that will look into your case and help make a determination. The Center for Medicare Advocacy and the Medicare Rights Center are two really great resources for understanding legal analysis and policy and advocacy for older people and people with disabilities who have Medicare, and they both provide self-help packets for many different kinds of appeal situations, so that you can get more counseling, more advocacy, and more assistance with understanding what your rights are vis-a-vis Medicare. Next slide, please. And with all of that said, once you're home, with or without home care, there's the little matter of a post-discharge appointment. And we throw this slide in because we just want to make sure that there's communication that happens in the hospital that's really important to getting this done. When you are in the hospital, it's important to communicate to the staff that you want to make sure that they have reached out to the community doctor. So if you have a primary care physician or a specialist that the patient is seeing out in the community, when the discharge plan is happening, you want the discharge planner to help you make sure that the community doctor knows about the hospitalization and knows that a request for a follow-up appointment is coming. Let the hospital staff, you can ask them to let the community provider know what happened at the hospital and make sure that they transfer any records. You can also note that, and also have them or ask them to note that the patient or family caregiver is going to follow up for an appointment. While this is happening, you should also call the provider's office yourself to try to schedule the appointment and say specifically why your appointment is needed right away. This isn't just calling to schedule the annual physical or a regular checkup. This is, hi, my mom was in the hospital. I need to schedule a 7-day appointment. This was the diagnosis. Did you get the information from the hospital list? If you didn't, here's his phone number. Those are the kinds of keywords that we want you to use in order to ensure that these appointments get made. Next slide, please.
This is Carol again. One of the most important things that happen in the hospital, often with the pharmacist, and hospitals do have pharmacists on staff, they're important staff members. It's called medication reconciliation, or in hospital lingo, it's med-rec. So if you hear that term, it means medication reconciliation, which is basically the process of creating an accurate list of the medications, and that includes prescriptions, but also over-the-counter medications and any kinds of herbal supplements or vitamins that the patient has been on at home. And that is compared with the medication list that you're going home with. There will have been changes in the hospital, undoubtedly, and that medication reconciliation puts the two lists together and looks for overlap, looks for missing gaps, looks for information that would possibly mean the patient is taking too much of a medication or not taking an important medication. So this is a role in which family caregivers have a particularly important place, because often the family caregiver is the one who has followed the medications, knows exactly what they are and how much, what the dosage is, and all of the other things. So it's important that the initial list be accurate and that it be compared very carefully with the discharge list. Oftentimes, things have been changed in the hospital because the hospital has a different formulary, a different drug that is basically the same drug as the one that you've been taking, but it just comes from a different manufacturer.
So here's an example. I had a situation where I was the caregiver to someone who had hypertension, and their regular doctor had prescribed nifedipine. She has CVD also. So she had nifedipine, which is a generic for Procardia, and then when she went into the hospital for something, they started giving her nifedipine, which is a different generic, also for Procardia. So when she went home, she had some Procardia from a primary care doctor, some nifedipine from a previous hospitalization, and some nifedipine. And we had to go through everything to make sure that we threw out the one that she wasn't supposed to be taking, because they all pretty much looked the same, but she took too many of the thinners at the same time, it would have put her at risk for fall.
That's unfortunate, but very, very common problem. And the illustration on the right there is from a book by Dr. Seuss, who's always a good source of information, called "You're Only Old Once," and it's called The Pill Drill. And people now do have, 10, 12 drugs, so it's really important that they be reconciled so that the management is that the right person is getting the right drug, the right dose, the right route, and the right time. And that's where family caregivers can be really, really important.
Next slide, please. So Carol already started talking about some of the facilities, the types of facilities where post-acute care can take place, such as skilled nursing, inpatient rehab, or long-term acute care hospital. Next slide. So I want to talk about just some of the difficult decisions about post-acute care that family caregivers may face. We recently released at UHF a series of four reports on a body of work called Difficult Decisions about Post-Acute Care and Why They Matter, where we went through patient perspectives and family caregiver perspectives, as well as the professional perspectives on the post-acute care transition, how choices get made, and what factors are limiting to choice. So to go through this relatively quickly so that there's time for questions, we wanted to make sure that we understood what were the things about post-acute care decision-making that mattered most to patients and why they were important. We know that patients who receive care from lower quality post-acute care providers have higher risks of complications and worse outcomes. And we know that choosing carefully can mean the difference between full recovery, cycling in and out of facilities, becoming a nursing home resident prematurely, or perhaps premature mortality or death. There are lots of external factors that limit the choice in what post-acute care facility you can use, such as insurance constraints, the capacity constraints of the facility, and whether or not they can provide the kind of services that are needed, as well as other system constraints like Carol talked about earlier around bundled payment and other regulatory issues. Next slide. So when we talked with caregivers and patients, they said to us the most important things about choosing a post-acute care setting were considering the location to make sure that it was convenient for family and friends, but some patients and family caregivers did say they would go further away for the right kinds of specific services. So if you need, for example, on-site dialysis, and it may not be in a location that was particularly convenient, but if you needed it, that's where they went. The intensity and availability of services. So for some conditions, frequent physical therapy is really important for recovery. So they wanted to make sure that they knew how often physical therapy would be offered, as well as what other disease-specific supports would be available to them. For some patients and caregivers, ongoing care availability was really important. It seemed clear for some patients that they would not be going home after short-term rehab, that the short-term rehab was to address whatever the acute issue was, for example, pneumonia or some kind of cardiac syndrome, but that they weren't going to be able to go home and that they needed to transition to long-term care. Would long-term care be available in the same facility, and would that be a smooth transition? Those were questions that caregivers and patients asked. And then finances. Is the facility in network with the insurance, and will they take on a patient that has extensive medication needs? Next slide. As Carol mentioned before, timing is of the essence and is also time is very short when being asked to choose a post-acute care facility during the discharge planning process. So there are a few public sources of information about post-acute facilities and post-acute care, but they have their limitations. The most common and most popular online sources, for example, are the Centers for Medicare and Medicaid's Nursing Home Compare and Home Health Compare websites. But some states have their own nursing home quality websites. For example, in California, it's calqualitycare.org from the UCSF School of Nursing. In New York, the New York State Department of Health has a nursing home quality initiative. There are other not-for-profit organizations like ProPublica that have Nursing Home Inspect, which provides some quality rating information. But a lot of the websites, the measures that they share are very technical, and there's less of an emphasis on the kinds of aspects that consumers want to know, such as quality of life, staffing adequacy, and communication, care coordination with patients and families. There are other things people want to know, like what are the facility characteristics, what's the patient experience, what do the reviews say, what's the food like, what's the general culture of a place, and what are the interpersonal aspects of life in the facility that are going to be important to patients and families. Those are harder to gauge, and they're typically not listed on these sites. Next slide. So before we wrap up, we want to just remind you that there are, in addition to the quality of care sites and in addition to other post-acute services like home care and home attendance, there are some resources out in the community that patients and caregivers can access post-discharge, and it's a good idea to talk about what some of these are with discharge planners while you're still in the hospital. Again, the transition doesn't end just when the patient gets home. The transition is over the duration of the recovery period, and it can last for weeks or months. So we suggest that family caregivers talk with the discharge planner about whether or not home care agencies, adult daycare providers, other social service agency referrals, transportation, any community supports from faith-based organizations or supports from disease-specific organizations, or even referral to use of any home life monitoring services like personal emergency response systems may be appropriate for the ongoing care plan.
Okay, we've talked a lot, given you a lot of information. I think summing up, next slide, please. I just want to stress that it may seem overwhelming, and in many cases it can be, but there are things you can do to prepare. There are things you can do while hospital stay is ongoing, and there are things that you can do to try to make the transition home or to a facility as smooth as possible. But you need help to do it. I don't think any caregiver can do this all alone. So you need to reach out to all of those people that Christina mentioned and your friends and family to help out too. And using the available resources can make everyone's role easier. And we suggest that you start with our United Hospital Fund Next Step in Care. That will give you many options to investigate. We thank you very much for your attention, and we'll be very happy to answer any questions in the time we have. And the final slide, if we have it, you can see our email addresses so that you can write to either one of us. But there were questions that were coming up.
Mm-hmm. So I see a question about whether the slides will be available, and I understand that Calvin and the team at FCA will be making the slides available to the participants at a later date. Can you confirm?
Yes, definitely I will.
Okay, and we see that there are a couple of questions that have come up. One of them is, where's the best place to go to find out your state regulations for power of attorney, advance directives, etc.? I've found that the American Bar Association is a good resource because it gives explanations to the more general differences between it explains what the different documents are and how to find what document is relevant to your state. So you can check your state health department for anything around healthcare proxy, durable power of attorney for medical care, or healthcare agent. You can check your state budget office or controller's office for things like financial power of attorney, and for other types of advanced directives, depending on what they are. So a DNR, DNI, that should all be on your state health department. But you can also ask for any of those documents from the hospital. There should be a patient advocate or a patient navigator that can help direct you to those documents, to the correct documents when you're on site if you need them urgently.
And you can also contact an elder law attorney who is experienced and knows the ins and outs of how to create these documents, so they are more likely to be observed than not, because that can also have an impact. So I think it takes a little digging, but they should be available in every state.
So I see a couple of questions about the right to refuse a discharge if the discharge plan is poor. So under the conditions of participation for Medicare, and typically under the Joint Commission standards, a discharge plan must be safe and adequate. So if you have concerns about whether the discharge plan is safe, adequate, and viable, then you can raise those concerns. I've found it personally helpful to say I have concerns about the safety of the discharge plan. And if you still have concerns, then that's the point at which you would reach out to your BFCC QIO. There are two. One of them is Levanta. The other one is KeyPro. And the one that governs your region is dependent on what state you're in. But if you go to there's a link on the desk for reaching out to BFCC QIO for your region, but you can also just Google BFCC QIO and you'll get a link to, and you just put in the state that you're in and it'll direct you to which of the organizations you need to reach out to.
Let me just add two things to that. The good thing is that these organizations will respond quickly. The bad thing is if they say, we agree with the hospital, this is a safe and adequate discharge, you or your family member may be responsible for that extra time that you were in the hospital. So it's worth, if this is really not a good plan, it's worth doing, but you should know the downside of it.
Okay. There are a couple of other questions here around, is there an organization that lists elder law attorneys by state?
Yes.
The National Association of Elder Law Attorneys is one good resource to use. So I would say that's a good place to start. There are other opportunities to get referrals to those kinds of services. You can certainly ask for your area agency on aging to refer you to an elder law attorney, or reach out to them through ACL. That's the Administration for Community Living. They may be able to have some resources. There are other local resources that you can look up, and your state bar association may also have a list of attorneys by specialty. And then, what opportunities do you see for community health organizations such as the Area Agency on Aging, Planning, and Discharge Planning in the community? Well, we're trying to address that. You know, there are different things that the caregiver advocacy and policy community are trying to do to make sure that these issues do get addressed, and one of them is just advocating for more training for social workers as well as hospitalists and other hospital staff involved in the discharge to make sure that caregivers like yourselves are integrated into the care plan as early as possible, and that care plans are really made truly specific to the context of the patient and family that they're addressing.
I think one of the things that would be important to do for a community-based organization is to have a brief training on the CARE Act, because that's something that's going to come up and that's important for people to know about. But whenever we talk to community agencies, they may have heard it, but they don't really know what it means. And so it's important to have a trusted source tell you about it. And we do have on the Next Step in Care website, for New York anyway, we have the guides for patients and caregivers.
Okay, and I just want to give two more resources before we're out of time, and I turn it back over to Calvin. BFCCQIO, that's the Beneficiary and Family-Centered Care Quality Improvement Office. That can be reached at Q, like Queen, QIOprogram.org. And if you go to that site and look for their contact zones, you can put in your state and find which one is the right office for you to call. And then someone asked a question about observation status and it not being appealable. That's correct, but there are fact sheets and self-advocacy checklists and packets that you can get from places like the Center for Medicare Advocacy and the Medicare Rights Center. MedicareAdvocacy.org and MedicareRights.org are those resources. And now we'll turn it back to Calvin at FCA.
Thanks so much. I just had one more question that I wanted to get asked, if you wouldn't all mind. It's from a patient advocate, actually from CANAR, which is California Advocates for Nursing Home Reform. They're a great organization in California. And he wanted to know, his question was, they often gets asked by patients if they have the right to object to a discharge to a facility that's hundreds of miles away. And I guess, is there a right to demand a placement close to home, friends and family?
I wouldn't begin to answer that question on a legal basis, because I don't know what the law is, but it would seem to me that that is, it's a poor practice, and that one would say you need to, for the adequacy of the discharge, you need to have someplace that is within reasonable distance of the patient's home.
Now, we understand that there are situations in more rural areas where the kinds of services required for the care of the patient may not be available in the immediate vicinity of the family, but there's always considerations. And again, I would think that that's a situation that you can talk to one of the advocates at the QIO organization. Now, remembering that the QIO organization they're basically an auditor of the Medicare program with regards to hospital stays and hospital appeals. So if you have some other insurance, then you may talk to the patient advocate at the hospital, or you may need to reach out to the care management offices at the insurance program that you're dealing with, and not necessarily the BFCCQIO for that situation.
I think that's more likely to occur with an inpatient rehab facility or a long-term acute care hospital, which are very specialized organizations and not likely to be readily available in a geographic distance. But nursing homes, it would seem that there ought to be some way to address that question to everyone's satisfaction.
Okay, perfect. Well, again, as you can see, both Christina and Carol's email addresses are on the screen. I will get the slides out to everybody. And I just wanted to thank both our guests for being with us this afternoon, as I think it's been made very clear they are the experts in this, this kind of dicey area of discharge planning. Dicey, unfortunately. But I'm also grateful they're able to stay a little bit after to answer questions I asked them before if they'd be able, and they're very accommodating. So I'm grateful they're able to stay a little bit after, answer some questions, and also work in all the questions that everyone asked previously into their presentation. So again, I'd like to thank you all for participating in today's webinar, which was again presented by Carol Levine and Christina Ramos-Callan. FCA webinars are a free and continuing series. You can find information on our next webinar on our website, which is caregiver.org. So thanks again, Carol and Christina, for joining us this afternoon.
Thank you.
Thank you.
The webinar is now concluded. We hope to see you all for the next one, and have a great afternoon.